And now we're going to move on. We're going to talk about endocrine, starting with diabetes. So the very first thing to understand about diabetes is that it's not a single disease. It's actually a group of diseases. So even though we often just say diabetes, the correct name is diabetes mellitus. So what does that mean?
Sweet urine.
Diabetes means fountain. So lots of urine. And then mellitus means honey. So it's lots of sweet urine. Now, contrary to what that name may imply, we will not be tasting our patient's urine. Do you understand? Now, in the old days, that's actually one of the ways that you would know if your patient had diabetes but we don't do that anymore. So now we have chemicals that do it for us.
Wouldn't you like get on the sidewalk and have ants if the ants went to it?
I guess that would be a way to do it. So in this case, though, we're not doing that. So what characterizes diabetes, the reason there's sugar or glucose in the urine is that there's excess levels in the blood. So we're going to talk about some general characteristics of diabetes, and we're going to talk about the two major forms of diabetes. There are some others, but we're just really going to focus on the main two types. And they are conveniently named type 1 and type 2. So kind of like Dr. Seuss here. Hold on just a moment. It looks like I'm obsessed with colors, but these are not mine.
Really
I'm stealing them. Yeah. All right. So the defining characteristic is elevated glucose in the blood. As far as diagnostic criteria goes, there's several different ways we can diagnose it. So you can do what's called a fasting plasma glucose, FPG. And if that is greater than 100, sorry, if it's less than 100, your patient is normal. If they are between 100 and 125, then they are considered to be pre-diabetes. In the old days, we called this impaired glucose tolerance. Now we call it pre-diabetes. And then if they are above 125, so 126 and above, then your patient is considered to be diabetic. Now, this is for what kind of glucose? Fasting plasma glucose. Now, you can also do what's called a casual or random blood sugar. And if that's above 150, we typically would consider that to be diabetes. Casual or random. Yeah. So that's casual or random. And then we also have what's called postprandial glucose, which means after a meal. And that's going to be calculated typically as 2 hours after beginning a meal.
What is it called?
Postprandial. Yeah, post meaning after and prandial meaning eating. So 2 hours after a meal is considered postprandial. No. The last thing that we have is something called hemoglobin A1c. Now, what's normal adult hemoglobin called? Hemoglobin A. So what is this 1c thing? Well, as it turns out, how long does a red blood cell last?
4 months.
About 4 months. So during those 4 months that it's alive, it's floating around in sugar water, right? So a certain amount of the chemical in it is going to get sticky or glycated or glycosylated. Don't ask me the difference between glycation and glycosylation, who cares? Sugar sticks to it and bonds to it chemically. So you can think of it as it becomes sticky with the sugar. Now, do you think that the amount of hemoglobin that becomes sticky is going to be higher if the blood sugar is higher? Sure, that makes sense, right? The sugarier the blood, the more likely some of that hemoglobin is to become sticky. So the percentage of hemoglobin that has been glycated is called hemoglobin A1c. So normal is less than 5.5. Glycosylated or glycated, either one can work for you. So So glucose, change the glue to a Y,
Yeah, I got it.
and then 8.
But it says that it's
There's no C
on here.
Of course it does. You do not have Microsoft Word Medical Edition.
Is that a thing?
Yes. I don't think it is. You just have to add it to your dictionary. Okay. So less than 5.5% is going to be considered normal. And then once you go above a certain level, drawing a blank at the moment,
5.6 to 7.
5.6 to what?
7%. It's controlled diabetes.
Well, hold on.
Oh,
Okay.
sorry.
So once you go above 5.5%, we're considered to be pre-diabetic. And then I want to say it's 6.5% is considered diabetes. Yeah. So you've got normal, and then you've got your pre-diabetes, and then your diabetes.
So it's not controlled and uncontrolled?
Hold on. Okay, so you don't have diabetes if your hemoglobin has never been above 6.5. Does that make sense? So, okay, don't look at your computer. Look up here.
I'm reading my notes.
I know. Hold on. Okay, so let's say you started out in life with a hemoglobin A1c of 5.2%. And then as you develop diabetes, over the years, you slowly go up to 5.6%. Okay, you don't have diabetes yet. What do you have? Pre-diabetes. Now, let's say that eventually, as things go up, you get 6.8%, 7.2%. Now, at 7.2%, are you controlled? No. But let's say with lots of work and drugs, you end up and eventually you get back down to 6.4%. What do you have? Controlled diabetes. Does that make sense?
Yeah.
Yes, I know. So once you've had diabetes, even if your hemoglobin C comes all the way back down to here, we're still going to call it controlled diabetes. But if it never reaches the threshold for diabetes in the first place, you're going to stay in the pre-diabetic category. Does that make sense? Yeah. All right. So the important thing is that hemoglobin A1c provides us with kind of like an average of what your blood sugar has been doing over the last 3 months or so. In the old days, hemoglobin A1c was only used for management of diabetes after you had been diagnosed by fasting plasma glucose. Nowadays, they have like better technology for the hemoglobin A1c, so we can use it for screening as well as for management. So you can use either of them for screening, and then for the management, we typically want to use hemoglobin A1c. Now, every now and then, someone will have normal fasting blood glucose, but their A1c will still be high, and that's typically when we want to check the postprandial glucose. Does that make sense? So generally speaking, what you want to check is fasting plasma glucose and A1c. And then if those two aren't matching up, then you look at postprandial as well. All right, but for our purposes at the moment, we're just talking about high blood glucose. Now, some of the cells in your body can take up glucose without any additional help, such as your brain cells. Your brain cells don't need any additional thing in order to be able to absorb glucose. But most of the cells in your body do require something else, and that something else is a hormone that we call insulin. So insulin is produced from the beta cells of your Isles of Langerhans, named after Dr. Langerhans. By the way, you've heard of him before, right? Because he has some skin cells named after him too. What are those? Langerhans cells, which are macrophages in the skin, and sometimes dendritic cells too. You remember that from Pathopharm? Mm-hmm. No, I don't. Never heard of that before. Okay, so the beta cells are in the pancreas. Most of the pancreas is an exocrine organ. What does that mean? It secretes what? Not hormones. other stuff. Yeah. But there's little pockets, islands of cells in the pancreas that are not exocrine, they're endocrine. What does that mean? Now say hormones. They secrete hormones. And the major hormone secreted is insulin. So there are two major reasons why blood sugar would be high. And one of those is if we have lower insulin production. So if something is attacking the beta cells and destroying them, they're not going to be able to produce as much insulin as usual. And eventually you get to the point where they can't produce any insulin at all. That particular disease process is called type 1 diabetes. Now, say again? Yeah. Now with type 1 diabetes, what caused it in the first place? What do we say happens to the insulin production? It goes down. Why does it go down? Because something's attacking the beta cells. What would be attacking the beta cells?
Infection.
Not an infection.
The body?
The body? What's it called when the body attacks itself?
Autoimmune.
It's an autoimmune disorder. Now, similar to the schizophrenia hypothesis, where there's kind of like a fragile or vulnerable brain, vulnerable genetics, we believe that there is a similar pattern with diabetes. So you're not born with diabetes, you're born with a genetics that is susceptible to diabetes. And part of the reason we think that is a lot of times type 1 diabetes onset is after a severe infection. So the patient will get sick, they'll have like really bad viral infection or some bacterial infection, and then that's when they start to develop diabetes. So type 1 diabetes develops rather slowly at first, and then it accelerates kind of towards the end. A lot of times patients will have initial symptoms that coincide with another illness. So they get sick, and that's where we get diagnosed them with diabetes. Then they get better from the illness, and the diabetes gets better too. Now, imagine for a moment you're a little, oh, by the way, when does type 1 diabetes tend to occur? In young people. So it used to be called juvenile onset because it mostly happened in kids. Now, it can happen in young adults as well, and rarely it can even happen in adults as old as 30s or even early 40s. That's called late onset or latent onset of adult diabetes, but who cares? The important thing is it's not just kids, although the vast majority of them are children. So imagine for a moment you're a 13-year-old kid who got sick and then got in the hospital with diabetes. They said, you have this disease, you're going to have it for the rest of your life. Now, being a kid, what are you going to think? No way! This is not happening to me. What's that called? Denial. Now, you get better, and you go home, and you don't need insulin. You got better. Now what do you think? I'm cured. Stupid doctors and nurses didn't know what they were talking about. I'm special. I'm a miracle. So we call that the honeymoon phase. So when they got sick, their need for insulin rose. Their body couldn't meet the demand. They ended up getting diagnosed. But after they got better, their body was able to meet their insulin needs at least somewhat for a while longer. And then eventually it goes down again to where they really need the insulin. So that phase where they don't need insulin in the middle there, what's it called? The honeymoon phase. And unfortunately, it feeds into the unique psychology of children. Well, and all adults, all humans, I guess. To feel like, no, I'm special, this isn't going to happen to me. Dumb doctors didn't know what they were talking about. So that's kind of type 1 diabetes in a nutshell. What causes it?
Autoimmune disorder.
Autoimmune disorder that destroys what?
The beta cells.
Beta cells where?
In the pancreas.
In the pancreas. So that there's less what? Insulin production. And eventually, how much insulin production is there? 0. So this is a case where, what's the ultimate treatment for type 1 diabetes? If your body is not producing insulin,
Give it insulin.
we need to give insulin. So up until the moment in time where we were able to successfully extract insulin out of animals, if a person was a type 1 diabetic, they were going to die. So anyone you know with type 1 diabetes is a modern medical miracle, because without the ability to first extract it from animals and now to create it with recombinant DNA from bacteria, they can't live. They would die within weeks, if not earlier. So that's type 1 diabetes. Type 2 diabetes is a little bit different. And in type 2 diabetes, the problem isn't that there's not enough insulin, at least at first. The problem is that the cells are not listening to the insulin signal. Now, the reason for that, what's it called when someone doesn't listen to you?
Selective hearing.
Okay, sure. So if I tell you you should study a certain way and you decide you're not going to, what would we say you're doing?
Following the rules.
I'm not your parent. I would say that you are resisting. No, I'm not going to do that. So you're resisting. So when cells don't listen to the insulin signal, we call them insulin resistant. Now we're going to talk a little bit more about what insulin does in just a minute, but insulin is a storage hormone. It tells fat cells and liver cells and muscle cells to take up glucose and triglycerides and store them for later. Now, if those cells are already full, are they going to be able to take up the glucose and take in the triglycerides?
No.
No. So the reason they're resistant most of the time is because they're saying, well, we're already full. We can't do that. Does that make sense? So one of the major driving factors of insulin resistance, guess what it is?
Diet.
Okay, what about your diet?
Too much fatty. Foods, sugars, fat.
It's not about sugar versus fat. It's about too many calories. So another way to say it is that an energy surplus chronically is what ultimately leads to insulin resistance. Now, what happens to people who are in a caloric surplus chronically? They gain weight. Yeah. So one of the major risk factors for getting type 2 diabetes is obesity. So if you think about it that way, that a cell that's full doesn't want to respond to insulin. It's going to be resistant. So when you think about it that way, it makes sense that, well, how does it get full? Well, you're feeding the body more than it can handle. That excess energy has got to go somewhere. And so if you're not burning it off, it needs to be stored. Once the storage cells are full, what do? Well, you can build more storage cells, but that takes time. So in the meantime, you are insulin resistant. Now, that would also imply that the two things you might want to do to solve the insulin resistance problems, what would those be? Okay, eat less. Okay, exercise. Use the muscles. When you use the muscles, the glycogen gets used up, and now the muscle cells are empty and can absorb more glucose. So muscles that have been used are much more receptive to insulin because their glycogen stores have been depleted.
This could be like a sleep question. So then is diet and exercise
The major treatments for diabetes? Yeah. Yep.
people are just lazy, so they don't. They're probably not that much.
Well, let's not say lazy. They're what? Not compliant? I don't even know if I want to use the word compliant.
They just choose not to use that.
Oh, okay. Now, we'll talk about management a little bit later. So we'll get into some of those psychosocial issues later. Yes.
So you said it causes them to use the muscles, which causes the muscles to take up.
Right. So when you use muscles, you use up glycogen storage. So now there's an empty space inside the muscle, metaphorically speaking. So now when insulin comes around, the muscles go, sure, I'll take in that glucose. They don't say, no thanks, I'm already full. Okay. All right, so let's talk about the common things with diabetes. As blood sugar goes up, so as glucose goes up, some things are going to happen. And the first thing that can happen is once the blood sugar goes up above 180, some of the glucose is going to what we call spill into the urine. Now, in your kidneys, you've got these chemicals. Their job is to pull glucose back into the blood. So your body doesn't want to have sugar escape in your urine because your body's designed not to die of starvation. And letting energy just get peed out, well, that's not very efficient for survival. So your body's designed to pull that sugar back in. Does that make sense? Up to how much? Up to 180. But once you go above 180, there's more glucose than those little pathways can handle. So some of that glucose is going to begin to spill into the urine. And that is going to result in something called Glycosuria. So glucosuria, just change the U to a Y and you've got Glycosuria.
The U, no. Oh.
Yeah, no, you don't change the urea, you change the gluco. So, now, as glucose is in the urine, it's going to increase the osmolality of the urine. What do you know about increased osmolality? What is osmolality a measurement of? The answer is not what? Say again? Okay, what is osmolarity a measurement of? Concentration. So, what is it that drives osmosis? Concentration gradient. So when there's more concentration somewhere, water is going to rush into that area. So glycosuria causes increased concentration of urine. That in turn is going to cause more water to go into the urine, which is going to cause an increase in urine. So what's an increase in urine called? Polyuria. So this increase of urine production because of an increased concentration is called osmotic diuresis. What's the driving factor in osmotic diuresis? An increase in the urine concentration. And in this particular case of diabetes, what is the cause of the increased concentration? Glucose in the urine. And that's going to start to occur at what level? Above 180. Now, at above 180, when you do a urinalysis, you're going to see glucose there. You're not necessarily going to get polyuria at 180. It's probably going to have to be like 300, 400, 500 before you start seeing large amounts of polyuria. Does that make sense? So it's not a yes-no switch. It's a gradual increase. Okay. So the first symptom is polyuria, and it's driven by osmotic diuresis. Now the second one is you're going to have an increase in blood osmolality. I guess that could be first, but who cares? Now, what's osmolality? It's a measurement of concentration. So, do you remember the equation for blood osmolality?
2 times sodium plus BUN plus glucose over 18.
It's almost like you can read it. Yeah, so 2 times the sodium plus the BUN plus the glucose divided by 18. Now, when the blood glucose is only 100, what's 100 divided by 18, more or less? It's about 5. When the blood glucose is 400, what's the osmolality of glucose? 400 divided by 18. It's about 20. So it's 4 times higher than usual. So as we get increases in blood osmolality, what's the main driving factor of osmolality most of the time? Now, imagine for a moment that you ate a bunch of sodium. How would you feel?
Bloated, thirsty.
Thirsty. Okay, so when you increase blood osmolality, how does a person feel? Thirsty. Now, does it matter whether you're increasing it with blood sugar or whether you're increasing it with sodium? No. What's the end result? Thirsty. So a person who is thirsty, what do they want to do? They want to drink more water, and that is called polydipsia. Now, a person who drinks more water, what are they more likely to do? They're more likely to go pee. So it's kind of like a mutually reinforcing engine there. The more water you drink, the more you pee. But you're also producing more urine than usual because of osmotic diuresis. So ironically, a person who's in this situation can be becoming dehydrated or hypovolemic even while they're drinking all this excess water. And again, this is not something that happens at relatively low levels of blood glucose, like 150, 180. This is something that's going to happen as they go above 250, 300. Now, the third thing that happens is, and this is much more so in type 1 diabetes than type 2 diabetes, because in type 1 diabetes, there's no insulin unless the patient gets it exogenously. Whereas with type 2 diabetes, there's still some insulin there, it's just not working as well as it should, right? Mm-hmm. So this last one is something that happens when a cell is awash in blood sugar, but it can't get it. So if a muscle cell or a fat cell or a liver cell is like, hey, we really want the sugar, but can't get it, what's it going to start to do? If you were surrounded by food, but you couldn't eat it, how would you feel? Sad and hungry, and eventually it would hurt, right? Yeah, so that's basically what happens to those cells. So your cells begin to send out little signals, hey, give us some energy, buddy, we need some glucose around here. And then that gets translated up in your brain, and your brain says, I'm hungry. And so that is called polyphagia. Now, as a person eats, what does it do to their blood sugar? It increases it, which drives this engine of polyuria. So one of the things that can happen to a person in this phase is that they can lose weight while eating anything they want, because they're literally peeing out the food they eat. I've known of a patient who lost about 100 pounds. Leading up to his diagnosis of diabetes. Now, this is in type 1 diabetes. It's not going to happen in type 2 diabetes. So, what are the 3 classic signs and symptoms of elevated blood sugar? Polyuria, polydipsia, polyphagia. Now, the polyphagia in particular is most likely to occur in what kind of patients? Type 1. Now, all 3 of these are more likely in type 1, but they can still happen in type 2. But that last one particularly, you're not going to see it until you get to type 1. In addition to those 3 classic signs and symptoms, I'm also going to include blurred vision. Patients with high blood sugar levels will often complain that their vision is blurry, and as their blood sugar comes down, they say their vision kind of resolves. Now, if a person is in this polyphagia stage where their cells are starving, they can't get any glucose, eventually what's going to happen? If you can't use the glucose for energy, your body's got to come up with some other form of energy to use, right? Mm-hmm. So it's going to start to use fat as an energy source for things that ordinarily wouldn't be used for. So we're going to take the fat and we're going to turn some of it into ketones. Ketones can be used by tissues in place of glucose. Now, how is this different from ketosis in a ketogenic diet? Okay, so the major difference is in a ketogenic diet, there's still insulin around, and the insulin is still telling glucose to go into cells. There's not a lot of glucose, but there's enough. In the case of this, which is ketoacidosis, there's no insulin, there's not enough insulin around to do its job. So there's blood sugar everywhere, but there's not enough insulin. So patients in this case, we call this ketoacidosis. So they're going to be producing so much ketones that the patient's going to become acidotic, and they're kind of literally starving to death at the same time. Serena?
But don't they have, so they don't have any glucose, you said? This is they don't have glucose?
No, a person whose ketogenic diet is eating low amounts of carbohydrate. So they're not going to have a lot of glucose. But they still will have some glucose being pushed into cells because they're eating protein still. And protein can turn into glucose. You can also do gluconeogenesis. So, and then they're still going to eat some tiny amount of glucose, of carbohydrate. So it's not that there's no glucose, there's some. And that is still being pushed into cells by insulin. But in diabetes, what's happening is that there's tons of glucose around, but they don't have the insulin to push it into their cells. So their cells are starving to death. So it's a different disease process. There's ketones in both processes, but they're very, very different. So you can live in ketosis from a ketogenic diet for a long, long time without problems. Well, certain problems anyway. You're not going to die from a ketogenic diet most of the time. Can't say you won't, but you're probably not going to. But in the case of ketoacidosis, the patient will die if it's not corrected. So, what do we remember about acidosis? No, what do we remember about acidosis? That just means like Pathopharm 1. I don't remember. Okay, so in acidosis, what are the two major causes of acidosis? M and R. Respiratory and metabolic. In this case, what would it be? Metabolic. So it's a metabolic acidosis. So what would you expect to be low? Bicarbonate. And then what would you expect the body to do to compensate? Respiratory something, right? So how would you go into respiratory alkalosis to compensate? What would the body be doing? What would the person be doing? Breathing, not less, more. So you want to get rid of as much carbon dioxide as possible. So that's going to manifest as someone muttered it under their breath. Kussmaul breathing. So Kussmaul breathing pattern. So what is a Kussmaul breathing pattern? Really big, deep breaths. So imagine for a moment that you just ran a 600 meter. Now, how many of you have ever run a 600 meter? It's like the most evil race in the whole world. It's like a little bit longer than a sprint, but not long enough that you can like just run. You've got to like sprint-ish the whole thing. It's horrid. How do you feel at the end of it? What do you breathe like? Well, that's kind of Kussmaul breathing. Does that make sense? Okay, so your patient won't be doing Kussmaul breathing in the more severe stages of ketoacidosis. Their breath, they're going to be breathing out acetone, so they call that a fruity breath. Now, many of us think juicy fruit. Like, oh, I like the smell of fruit. No. It's like kind of like a rotten fruit smell. If you've ever been like at a dumpster behind a restaurant, that's more like, yeah, it's not a pleasant fruit smell. So you've got Kussmaul breathing, you've got the fruity smell, you've got low bicarbonate levels. Now, what would you expect potassium to be? You expect it to be high because it's what? It's acidosis. And in acidosis, your body tries to exchange potassium for hydronium ions, hydrogen ions. But there's something else happening here that short circuits that it makes potassium low. What is that? It's actually on the board. It's the polyuria. So the patient is actually peeing out all of their potassium. So even though you would expect it to be high, it will actually be low because of the osmotic diuresis. So what do you think the treatment for ketoacidosis is? Say it again. Yeah. Spit it out. Insulin. Right. What kind of insulin?
Just regular.
Yeah, how would we give it to them? We give it to them IV.
Oh.
Now, at the same time, you might also give bicarb and you might also give potassium. As the blood sugar normalizes and the acidosis resolves, you've got to make sure that you don't over-administer potassium, because then the patient will go into hyperkalemia. So in addition to monitoring blood sugar, what else are you monitoring? Potassium levels and bicarb levels. Yeah. All right. Any questions about ketoacidosis? Now, with type 1 diabetes, the way that most patients are diagnosed is by going into ketoacidosis. So, so what happens is, their immune system is attacking their pancreas and their insulin level production is going down. They get sick and it goes way down. Ketoacidosis, get diagnosed. Then they get better and continue this again, and they don't have problems for a little while longer. And then here they have problems again. So what's this time period in between called? Honeymoon phase. All right. So what's the way that most type 1 diabetic patients get diagnosed with type 1 diabetes? Ketoacidosis. All right. Now, these are all symptoms of acute high blood sugar. What do we mean by acute high blood sugar? The blood sugar goes up and you get symptoms. That's what we mean by acute symptoms. No, I'm not going to give you a specific number. But the higher it goes, the more severe the symptoms. So these are not, you don't have to wait like 20 years to get these symptoms. As blood sugar goes up, they develop. Does that make sense? Okay. The next thing we're going to talk about is long-term complications of high blood sugar. So, over time, it's not just hemoglobin A that is being glycated with sugar. It's other tissues in your body as well, including your, primarily being the arteries and capillaries throughout your body. So over time, those capillaries and arteries are being glycated as well, which can lead to inflammation and then loss of function in whatever that tissue is. So there's 3 major complications that are long-term complications of elevated blood sugar. So what's the driving factor behind these complications? Say again? Well, glycation of arteries and capillaries. So there's 3 major classes, and then I'm going to give you a 4th one that's a little bit newer. So the first one is retinopathy. Now, what do you think is happening there? Okay, so your eyes are being damaged. What's that ultimately going to lead to? Blindness. So depending on where you read, either high blood pressure or diabetes is the #1 cause of blindness. So they're probably about even. Now, some patients like to have both at the same time. Their risk is even higher. Now, this is not something that happens overnight. How long does it take to occur? Yeah, 20, 30, 40 years. So it's going to take a long time before it happens. So this can occur even at relatively low blood sugar levels. So if you have blood sugar levels of, say, chronically 150, 180, it might not even be high enough for you to have glycosuria, but you still have this very low level of damage occurring, which can ultimately lead to blindness. The next one is nephropathy. So what's being damaged in a nephropathy? Nephrons, which are inside the kidney. Okay, so it's the functional unit of the kidney. As you damage nephrons, what happens to kidney function? It goes down. Now, what is the ultimate sign of kidney damage? Like, yeah, how do you know a patient's got kidney failure? Yeah. Okay, so elevated creatinine levels and BUN levels. So that would be your ultimate, I think this patient's in liver failure, or sorry, in kidney failure, right? But the earliest signs are actually going to be proteinuria. Now, what's the number one protein in your blood? Albumin. We've talked about how you do your analysis, right? In Pathopharm 1, how do you do your analysis? Okay, well, you pee in a cup. Okay. You give the cup to the tech. What does the tech do? They dip the little dipstick in there, and then they what? You're supposed to wait a certain amount of time, and then you compare the color, right? Yeah, that looks like that. Okay. So, a regular urinalysis is not super sensitive at detecting very small amounts of protein in the urine. So, if you see proteinuria in a urinalysis, that means there's quite a lot of damage. So in diabetic patients, you can actually do a more sensitive test called a microalbuminuria. What's the number one protein in your blood? Albumin. So what's the difference between proteinuria and microalbuminuria? It's more what?
Specific?
No, it's more sensitive. It can detect smaller amounts of protein. Now, the microalbumin test is more expensive. So what do you do first? You do the regular urinalysis. If it's proteinuria, do you need to do microalbumin? No. But if it's normal, could they still have protein in their urine? Yes. And how do you know that? Microalbumin. Now, microalbumin is not something you do in the hospital typically. It's something that's done on a primary care basis. And it's usually only done once a year. All right, last thing we need to talk about as far as the nephropathy goes is to reduce the risk of nephropathy, we're going to want the patient to be on a drug class called ACE inhibitor. Now, we're not going to learn any ACE inhibitor names for now. But for the next test, for test 3, cardiovascular, you will. So, but for right now, all you need to know is ACE inhibitors do what? Reduce the risk of what? Nephropathy. Okay. All right. The last one is neuropathy. So what's being damaged there? Neurons. And this can take one of two forms, what's called either central or peripheral. Peripheral is going to be hands and feet. Which of them is probably going to be more likely? Feet. You've got poorer circulation in your feet to begin with, and so it's more exposure to the glucose and less blood flow in general. Your feet are more susceptible. Over time, this can lead to neuralgias, and it can also lead to numbness. So in severe cases, you'll have patients who have both. So on the one hand, they can't feel normal touch, but on the other hand, you like barely brush their skin, they're like, it hurts. So pretty nasty. It can also cause well, if you've got the decreased sensation over time, you don't feel when you're hurt. So I've had a patient, for example, that he stepped on a tack and he didn't feel it. And 4 days later, he comes into the office saying, "Oh, so what's going on today?" He's like, "Well, my foot is bleeding." "Well, how do you know your foot is bleeding?" "Well, my wife said I was bleeding on her carpet in the bathroom." So, and it turns out by that point he's got gangrene in his foot because it's infected and nasty. So because of that, there are increased risk for infections and then increased risks for amputations. They're also at risk for something called Charcot Joint. Now, how many of you are familiar with Hansen's disease? Anyone know what that is? You probably know it by a different name, leprosy. So what happens in leprosy?
You start losing your...
You become deformed over time because you start losing extremities and stuff. Why do you lose extremities and stuff? What is it the person has in leprosy? What's the defining characteristic? Say again? The why. They can't feel pain. Now, if you can't feel pain, you don't know when you've been injured, and you don't know when you're inflamed because you can't feel the tenderness. So over time, they aren't getting appropriate help because they don't even know there was a problem to begin with. And so over time, they get more and more tissue destruction until eventually they're deformed. And that same process can occur in the feet of patients with diabetes, and that's known as Charcot joint. The number one, let me just, as long as we're here, let's also just say, so retinopathy, nephropathy, neuropathy. The other one is just damage of small capillaries. And this can lead to decreased wound healing. So when you combine the peripheral neuropathy with decreased wound healing, you get the number one cause of amputations in the United States is diabetes. Now, central, and peripheral diabetes tends to be from the extremities upwards. So it starts the extremities and then works its way up. So sometimes you'll hear them talk about stockings and gloves. So like they have neuropathy like from here down and then like from here down. The central neuropathy is neuropathy of larger nerves, and that can sometimes be your like your vagus nerve, for example, which in turn is what causes peristalsis. So a patient who's got neuropathy of their vagus nerve might end up having elevated heart rate because they can't control their heart as well, and they could also have constipation and gastroparesis because they don't have adequate peristalsis. So they eat something and the food just sits in their stomach. Now they've got a food full of stomach for several hours. What's more likely to happen? Indigestion and GERD, acid reflux. Okay. And then it's just sitting in their digestive tract, not really moving along very quickly, so they're more likely to have constipation. So that would be central neuropathy. All right, now as far as the small capillaries go, there's one last one we need to mention, and that is erectile dysfunction. Erectile dysfunction and diabetes are kind of like love and marriage. You can't have one without the other. Good old Sinatra. All right, any questions about these complications?
For the damage of the small capillaries, is that part of your peripheral, or is that just like a big, one of like the major?
It's still one of, it's a major one.
Okay.
Yeah.
Thank you.
Yeah, it interacts with the peripheral to increase the risk of amputations, but it's separate.
Okay. Thank you.
Okay.
And
All right.
erectile dysfunction is a subsection of small capillaries.
Yeah, and rather than capillaries, I should say small arteries or arterioles. Okay. So it's not the capillaries themselves that are the problem, but the arterioles leading up to those capillaries. As they get damaged, it decreases blood flow, leading to erectile dysfunction and poor wound healing. Now, all of these, so 1, 2, 3, 4, so retinopathy, nephropathy, neuropathy, and small arteries, all 4 of those are considered microvascular. How long does it take for those to occur? Long time. Now, who's more likely to get them, a type 1 or a type 2 diabetic? Type 1, why?
Because they got it when they're younger.
Well, first of all, they typically get it when they're younger. So if a person gets it when they're 12, by the time they're 42, they've had diabetes for 30 years. On the other hand, if a person who has type 2 diabetes typically is older, so let's say they get it when they're 45, what's 30 years for that person? 75. Now, the other thing is that because a person who has type 2 diabetes has kind of like a very slow slide into it typically, they don't go from like blood sugar of 70 to blood sugar of 400 overnight. It's usually several years developing. They just have a slower development into the diabetes. A person who's got type 1 diabetes, because they don't have any of their own insulin, it's just a little bit harder to control blood sugar in general. Now, the advent of modern insulin pumps and then also continuous blood glucose monitoring helps, because you can give real-time feedback and much tighter glucose control than we could with just giving shots of insulin a couple times a day. So it's better now than it has been at any time before, but type 1 diabetics typically still have an increased risk of these over type 2 diabetics at an earlier age. Any questions about microvascular complications? When do we get them? Later on. Can they occur if a patient doesn't have glucose in their urine? Yes. So sometimes older patients will think, well, as long as there's no glucose in my urine, I'm okay. But you can still be developing these even at relatively low blood sugar levels. So like 150, 140, you can still develop these. Now, the other type of vascular complication is called macrovascular. So these are all micro. And now we've got macro. And the macrovascular complications are coronary artery disease, stroke, and peripheral arterial disease. So with coronary artery disease, what's the number one thing that happens? It is multifactorial. But what is coronary artery disease? The disease of the coronary arteries. What happens if you have a blockage of your coronary artery? You could die. And what would that be called? Dying from what? A myocardial infarction, which is a fancy smancy way of saying a heart attack. So coronary artery disease, heart attacks. Cerebrovascular disease, strokes. And then peripheral arterial disease, part of that goes back to this wound healing issue. And then part of it is also intermittent claudication. So there's not enough blood flow to your muscles when you use your legs, so you end up getting leg cramps. What's that called? Intermittent claudication. Now, I once heard someone say that macrovascular complications kill you, strokes and heart attacks, whereas the microvascular ones make you wish you were dead. That's what he said. But anyway, now for type 1 diabetics, microvascular were more common. For type 2, the macrovascular are more common. I guess I should say it the other way around. For microvascular complications, they occur at a higher rate in type 1 diabetes. For the macrovascular, they occur at a higher rate in type 2 diabetes. There's something about insulin resistance itself that increases the risk of stroke and heart attack, even if a person has normal blood sugar. And the risk of the risk of heart attack and strokes is elevated even in pre-diabetes. Does that make sense? All right. We are almost done in terms of time. Trying to think if we should talk anymore. No, please don't do it. Okay, so you've got the acute symptoms, the 3 polys, and you've got the long-term complications over years upon years, the macrovascular and the microvascular versions. We will drop off here, and next time we'll pick up with a little bit more detail about insulin resistance, and we'll also talk about all of the treatments. So learn your insulins, and I realized that we did not have a drug quiz for neuro.
We weren't gonna do that.
Oh,
If we wanted to, we can, but no.
but I thought everyone wanted to.
No.
Oh, you don't want quizzes. All right, fine, no quizzes for you.
I mean, if it's extra credit.
But, yeah. Wink, wink, nudge, nudge.
Maybe I'll just ask each of you a drug question in class.
And then we get extra points.
Thank you. And then if we get it, we can get it.
All right. All right, let's talk diabetes. So we talked about generalities of diabetes last time. So we talked about what is diabetes, and it's a group of diseases. It's not one single disease. And the ultimate result is elevated blood sugar levels. So those blood sugar levels can cause a number of acute symptoms. So we looked over those acute signs and symptoms. And then from there, we talked about long-term complications, and we divided those into micro and macrovascular. So remember, the microvascular ones were your apathies, retinopathy, nephropathy, and neuropathy. And then we also said erectile dysfunction. And then you can also say, to a lesser degree, decreased wound healing. And then the macrovascular complications were heart attacks, coronary artery disease, cerebrovascular disease, strokes, and then peripheral arterial disease, which can be manifested partially by your poor wound healing, but more importantly by intermittent claudication. So that was all last time. This time what we're going to do is we're going to talk about how we treat diabetes. And the way that we treat it is going to partially depend on what kind it is. So we're going to go in a little bit more detail about the different types. So the very first type we mentioned is type 1 diabetes. Used to be called juvenile onset because most of the people who got it were younger. We no longer call it that because you can still get it up into your 30s and even some people into their 40s. Question?
Yeah, can I go back a little bit?
Okay, go back.
How is osmotic diuresis related to polyuria?
Okay, so the question was, how is osmotic diuresis related to polyuria? And the answer is that osmotic diuresis causes polyuria.
Okay.
Glad I could answer that question. So, back to our story. So, type 1 diabetes is usually in younger folks. We talked about last time the vulnerable theory. So, you have a genetics that are vulnerable to developing type 1 diabetes. And then there's some sort of precipitating event, oftentimes a severe viral infection that precipitates the diabetes. And that typically occurs in late childhood, early teen years, but can also happen in young adulthood as well. Now, one of the ways that we can diagnose whether a patient has type 1 diabetes versus type 2 diabetes is by looking at C-peptide. So if you remember, the shape of proinsulin looks something kind of like that, right? So then we're going to cleave that protein there and there, leaving insulin and this peptide fragment. If you turn this peptide fragment this way, it looks like a C-peptide. So if the person is producing their own insulin, they're going to be producing C-peptide. If the only insulin that they're getting is the insulin you're injecting into them, then there will be no C-peptide. So, because patients who have diabetes need insulin a lot of times. So if you're giving them insulin, it's like, well, how do I know if their body's producing it? And the answer is C-peptide. So if you ever see that ordered, what are they trying to figure out? If the patient's got type 1 or type 2. So type 1 diabetes, we said, was an autoimmune disorder where your body is attacking which kind of cells? The beta cells of the pancreas. And so over time, insulin is going to go down to 0. At that point, or even before that point, if we don't give that patient insulin, they will die within a couple days to weeks. Right? Okay. So that's type 1 diabetes. And then type 2 diabetes is caused by insulin resistance. And so insulin resistance is when the cells that are responsive to insulin ignore the insulin signal that says take in glucose. And so what happens is the glucose levels will go up. So one of the major reasons why cells become insulin resistant is that they're already full of energy. So muscle cells and liver cells, that would be glycogen. In the case of fat cells, that would be triglycerides. So insulin tells your body to do a number of things. It tells muscle cells and liver cells to take in glucose and turn that glucose into glycogen, a storage form of glucose. It tells your liver cells to produce triglycerides and send those triglycerides out into the bloodstream. And then it tells your fat cells, the adipose tissue cells, take up those triglycerides and store them as fat. So insulin is an anabolic hormone. It's telling your body to store energy to create tissue. Sometimes people think that insulin is a bad hormone. Well, if you spike your insulin, that makes you fat. Well, only if you're eating more calories than you're burning. If you're not eating more calories than you're burning, then insulin is not going to make you fat, because it can't. In fact, bodybuilders will sometimes inject insulin into themselves in an effort to build more muscle. You eat food, and then you give yourself an injection of insulin, and your muscles take up more glucose than they would otherwise. And that gives you more ability to perform in the gym. So I'm not suggesting you should do that.
It's not very dangerous.
Yes, it's extremely dangerous.
Can you die doing that?
Yes, you can.
Perfect.
And bodybuilders have died doing that, but I guess anything to look good. So insulin is not a bad thing. We'll talk more about that later. But so insulin resistance typically occurs because the patient is already in a hypercaloric state. The muscle cells are already full of storage. So they're like, well, no thanks, I don't need this glucose right now. And that's why the blood sugar stays high. Now, if you tell someone something and they don't understand you or can't hear you, what do? No. You say it again, right? Mm-hmm. But this time, louder. So if someone doesn't understand you, if you say it louder, then they'll understand you, right? Yeah. Oh yeah, that's exactly how it works. Especially if they don't speak the same language you do. No, it's not how it works? Well, that's how we think it works, apparently. So basically, that is what your body responds to when your cells ignore the insulin signal and your blood sugar is still high. The way that your body responds is by producing more insulin. So in type 2 diabetes, we start with insulin resistance. Then the body's response to that is increased insulin levels, hyperinsulinemia. This is partially where insulin gets a bad rap. Well, you see, it's the high insulin that's causing the problems. Because hyperinsulinemia is associated with a number of problems. But that's actually not it at all. The hyperinsulinemia is a response to the insulin resistance, which in turn, most of the time, is being caused by a hypercaloric state.
So why do they produce more because does the body almost process it because they're not responding to it as if it's not there?
Not that it's not there, but just that there's not enough. So your body says, well, if your blood sugar is high, it's because you don't have enough insulin. Let's give you some more. So here's what happens in type 2 diabetes. So for a long time, you only need that much insulin. So guess how much your body produces? That much. But then, because of your hypercaloric nature, how many of you ever seen pictures of your parents as younger people? What do they often look like?
Skinny.
Skinny! And now,
Not so skinny.
not so skinny. Well, as they became not so skinny, especially the degree to which they become not so skinny, their insulin needs to have a tendency to go up. So guess what your insulin production does? It goes up too. There comes a point though where there's a cross and your body can't quite keep up with demand. What happens at this point? What happens right here when you can't keep up? Blood sugar. Blood sugar starts to go up. Okay, so you started getting the disease process here, right? Your insulin needs went up, and your body was able to keep that demand. But with this moment, when you have this cross, that's where you start to develop diabetes. But it doesn't start out as diabetes. What does it start out as? Pre-diabetes. Pre-diabetes is just, your blood sugar is up. It's just not enough for us to call it diabetes yet. But you've had the disease process for a long time. Typically, there'll be about 5 years between 5 years of insulin resistance with no symptoms. Then there'll be about 5 years of pre-diabetes, and then you get to diabetes.
When you're pre-diabetic, do they treat you as pre-diabetic?
Yes and no. So the approach to type 2 diabetes is going to be different than the approach to type 1 diabetes. What does a type 1 diabetic need? No ifs, ands, or buts. Insulin. They need insulin. What does a type 2 diabetic need to do?
Exercise.
They need to take that dotted line and bring it back down. How do you do that?
Diet and exercise.
Okay, diet and exercise. Now when we say diet, what do we primarily mean? What is the number one thing they need?
Less calories.
Fewer calories. Now ideally, we would lower the calories until they do what? Lose weight. And losing weight will help. But even if they don't lose weight, reducing calories is still the number one most important thing. Now, sometimes people are like, I don't get it. So let's think about it for a moment. Let's say that it takes 3,000 calories for you to maintain your current weight. But at this moment in time, you're eating 4,000 calories. What does that mean? This is per day, by the way. What does that mean? What's going to happen in your body?
Gain weight.
You've got about 1,000 calorie surplus every day, which is going to be used to help you grow outward. Outward. Okay. Males, females, mostly, on average, not always. But there's about 1,000 calorie surplus each day. Now, what would the person ideally do with their caloric intake?
Lower it.
Bring it to where?
3,000.
3,000, and that way they would maintain their even Steven, right?
Yeah.
No weight gain, no weight loss. Would that be ideal?
Yes, but not for diabetic. Yes.
No.
No.
We said weight loss was a good thing, right?
Oh, okay then.
So where would they need to lower it to lose weight?
2,000.
Okay, well you could, but you don't have to go that extreme. So let's just say that they lowered it to 2,800. Would they start to lose weight?
Yeah.
Yes. It would be slow, but they would lose weight. So ideally, they would go below their current maintenance calories. But even if they just went to 3,100 and they're still gaining weight, but slower than before, that's still better. Does that make sense? So if they lower their calories, even if they don't lower it to the point where they begin to lose weight, they're still going to be better off than if they stay up where they were before. So reducing calories is the number one most important intervention for that type 2 diabetic. Now, remember we said that the vast majority of diabetic patients are overweight or obese. There are a small group of type 2 diabetics who are not overweight, who are insulin resistant even at normal weight levels, but that's unusual. So there's a number of reasons why it could be outside the scope of our particular course. But the vast majority of type 2 diabetics, their insulin resistance is related to being overweight, and dealing with overweightness is going to help their insulin resistance. And in a lot of cases can cure them in the sense that they no longer are at risk for diabetes now or in the future as long as they maintain that lifestyle.
Is it true that gestational diabetes can be like a sign that you might be
We will talk about gestational in a few minutes. All right. So the first intervention is decrease calories. The second intervention is exercise. Now, what does exercise do?
Gets rid of the
uses your muscles.
It uses energy, and it uses the energy where in particular? In the muscles. So by draining the muscles of glycogen, or at least some of the glycogen, it makes them much more responsive to the next insulin signal. At the same time, exercise also mobilizes fatty acids, which are going to be in your bloodstream and be used for energy during your exercise. So when you combine a caloric deficit with exercise, what do you get?
Lots of weight loss.
Well, you can get lots of weight loss, but more importantly, what do you get? You get much better insulin resistance.
Wait.
An improvement in insulin resistance. You get a much better improvement in insulin resistance. Now, if you combine those two things along with weight loss, well, it's even better. Unless you're one of those normal weight insulin resistant people, in which case it won't matter as much. It will help, but it won't matter as much. Whatever I was going to say now. It's gone. So sad. No. All right. So let's talk about gestational diabetes just for a second. Oh, I remembered it now, but it's okay. So gestational diabetes. Gestational diabetes is elevated blood sugar that occurs during pregnancy. If the patient has it and it goes away and doesn't come back after delivery, then it stays gestational diabetes. If the patient's blood sugar stays high after delivery, then we call it type 2. So to answer your question, the answer is yes. Gestational diabetes is a risk factor for type 2 diabetes. And you might want to say it another way. It's a precursor, potentially.
So could your habits, like before pregnancy?
You could be predisposed to it. The pregnancy allows it to come out. And then...
Does, like, how, I don't know if it's like outside, but like why does like getting pregnant?
There's a number of reasons, and we're not going to talk about them in this course. So sad.
Lots of questions.
I know. So many questions. So many questions. Now, we used to call type 2 diabetes adult onset diabetes, and it's most likely to occur in middle-aged or late adulthood. And the reason for that, like you all said, what do your parents look like when you see pictures of them when they're younger? Skinny! Oh my goodness, I can't believe how skinny they were. You know what that means?
We ruined their lives.
No. What might you look like when you're their age? Yeah, there's an old saying among certain people. When you're dating that cute young thing, before you marry them, look at their mother.
Dang.
Because they might not always be that cute young thing. But it goes both ways. Not just for girls, it goes for guys too. So anyway, most of us have to take very deliberate measures not to gain weight as we get older. In the United States, especially, we have so much food available, and the food tastes so wonderful nowadays. You know, it's like they just know how to make food taste compelling. So it's easy to overeat. And the older you get, the less opportunity you have typically to exercise. I mean, think of from you to your high school self. How many of you were much more active in high school than you are now? How many of you sometimes like, man, I wish I could go back to that. But there's no way because you just don't have enough time or opportunity. Well, imagine when you've got 2 kids and a full-time job. They're going to have even less time to be active than you are now. So without making deliberate choices, you're going to end up looking like kind of like I did about 3 years ago.
You?
Yeah. I was 215 pounds. I looked like Santa Claus. Like my face was all pudgy, kind of like Fat Thor. Yeah, that was me. I'm Fat Thor. Yeah. I do. I'm not sure we're going to put it in the video, but yeah, I do have photos. You can see some of them on my website. Maybe I'll let you see them later. So I was about 215 pounds, and it came to a head when I graduated from high school. I was 145 pounds. Skinny little dude. Same height as I am now, skinny little dude. So then I went to the Air Force Academy and we did basic training, and they try and starve you in the military in basic training. So I actually lost 11 pounds. So I was this height and I was 135 pounds. No, 134. I looked like a skeleton. So then after that, yes. So then after that, life happens and stuff happens, and eventually I graduated from college. I was 172 pounds. Then I went and worked at the Breakers for 6 months while I was waiting to go to grad school. And I was a lifeguard and a beach attendant. So if you ever worked as a lifeguard or beach attendant, you burned a lot of calories. So I went down to about 165 when I stopped working there. But then I went up to grad school. And guess what you do in grad school? You get fat. So I had to take some measures and started doing karate and went back down to, I was 190 almost when I got married. Got back down to 185. And then you go on a honeymoon. And then you eat. So anyway, I stayed around 190.
Yeah, it's like that relationship.
Yeah. Yeah. What was the first thing you do when you start dating regularly? You get fat.
Yeah.
So I stayed 190 more or less until the first kid was born. Yeah, I gained the baby weight. So I started gaining a bit of weight. But by the time the kid is like four months old, we got it figured out. You can still work out on a regular basis. It's okay. Except that something else happened. My knees started hurting. Yeah, so for years upon years, I was like, you know what? I can eat whatever I want. I just have to exercise. But as it turns out, as you get older, you can't do enough exercise anymore because your knees won't let you. So, I'd done Slim and 6 and Power 90, which is the precursor to P90X. Then I did P90X, and for like 4 months, you can't sit down. Now you drop something on the floor and you're like, yeah, because everything is sore all the time because of muscle confusion, which actually doesn't do anything, by the way. And then I'd done Rush Fit, which was like, similar idea, but from a, what do you call it? From a